Good evening, doctors. I'm thrilled to welcome you all for today's informative webinar on air outside the lung, a complete guide to pneumothorax. I'm Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Sohail Mohammed. Dr. Sohail is an accomplished respiratory medicine specialist and an academician, currently serving as assistant professor at Al Amin Medical College, Vijaypur. A university rank holder in MD Respiratory Medicine from RGUHS. He has also earned top honors, including first prize in 34th PureView quiz conducted by CREST Crest. He previously served as assistant professor at Kanchur Institute of Medical Science, Mangalore, and is an active contributor to medical education as a CME speaker and postgraduate presentation moderator. Dr. Sohail's work reflects a strong commitment to teaching, research, and advancing respiratory healthcare. Over to you, Doctor.
Hi Vijay. Can you hear me? Hi Vijay.
Yes, doctor, you are loud and clear. You are audible.
So I'll just share my screen.
Yes.
Okay. Is it visible?
Yes, doctor, it is.
Okay. Hi. Thank you. Thank you, Vijay. Thank you for this kind welcome. And I welcome all the participants for today's webinar. I hope my voice is audible for everybody and my screen is visible. And let us begin with today's webinar. So today's webinar is on air outside the lung, where I'm trying to give a comprehensive and a complete guide for pneumothorax. We all know that our lungs are filled with air. But what happens if there is a presence of air outside the lung? Okay, so there is a dictum that the air should be always present inside the lung. If it is present outside the lung, in between the chest wall and the lung, that is what we call the pleural space, then it is not normal. So today we'll see how to identify those, what are the causes of these conditions, and how to diagnose and manage them. So before we begin, like I always do in all my webinars, I share some myth or fact with all of you so that you should know that these myth or fact are solved today, and you will come to know whether they are right or wrong, because day to day we see such cases in our daily practice. So let us begin with the first myth. So I just want to ask everybody, does all pneumothorax patients needs a chest tube insertion? That is the ICD insertion. That is what we call. So yes or no? All pneumothorax patients need chest tube insertion. Okay, good. I'll solve all these myth or fact at the end of the class so that you all will have an idea why it is yes, why it is no. Okay. Can giving oxygen helps pneumothorax resolve faster? Like, for example, a patient of pneumothorax has come and giving oxygen supplementation or support will help the pneumothorax to resolve faster. No. So most of them are telling no. Okay. The next myth or a fact is Does absent breath sounds always means pneumothorax? Okay, no. The next is small pneumothorax can be safely observed. That means we can do conservative management without going into any intervention. Okay, good. Tension pneumothorax always presents with hypotension. I hope you all know tension pneumothorax. If not, then we'll come to know at the end of the class. It's almost always presents with hypotension. Chest X-ray is sufficient to rule out pneumothorax in all cases. What do you think? Okay, we are getting no for this. No S, no S. Okay, fine. All right. So let us begin with today's webinar. I'll solve all these myth or facts at the end of the class. What I feel is you guys only will solve if you listen to this class carefully. So we all know there is air inside our lung. Our lungs are completely filled with air. They are the balloons which are completely filled with air. But still, we don't see any air in the pleural space. When I was discussing about the webinar on approach to pleural effusion, I told you there is a minimal amount of fluid present in the pleural space, especially for the lubrication and for smooth sliding of the lungs over the chest wall. But why there is no air in the pleural space normally? Why there is no air? Okay, so the pleural space does not have any air because it's a closed space. Okay, and there is no connection with either inside of the alveoli or from the outside atmosphere. Connection in the sense there is a clear-cut pathway. I'm not telling about the micro connection. The major clear-cut pathway is not there between the pleura and the inside alveoli and the outside atmosphere. And also important is the roles of pressures. We all know that pleural pressure is negative -5. That means with respect to the atmospheric pressure, it is negative for easy expansion of the lung. That is the expansion of the lung. That's why the pleural pressure is negative. Despite of this, we all know when there is negative pleural pressure, the air gets sucked in. Despite of this, there is no air. That is because the gradient exists, but there is no direct pathway. I have already mentioned it's a closed space, and air movement need two important things. The first is the pressure gradient and the second is the pathway. Pressure gradient we do have, but there is no pathway. So pleural space has pressure gradient, but there is no pathway. Upon that, when we see whenever there is this closed space seal is broken, the normal pleural space, the air will enter either from the alveoli or from outside the atmosphere through the broken chest wall. So the common causes are, it can be rupture of the alveoli that leads to leakage of air from lung into the pleural space, or it can be from the atmosphere where there is a trauma, blunt or penetrating chest trauma, where air enters directly from the atmosphere, or rarely there is a gas producing organisms which are present in the pleural space, which can lead to production of the gas that can be presented as a hydropneumo or a air in the pleural space. So what happens if the air enters into the pleural space? We all know why there is no air, but what happens if there is a air in the pleural space? So when air started accumulating in the pleural space, the pleural pressures become less negative. Less negative means it will move towards the positive side. Once the pressure becomes positive, the pleural space starts expanding. So the chest wall is very rigid. It will not expand outside. So the compressing part will be the lung. The lung started collapsing. The lung started collapsing as the pressure inside the pleural space increases. The lung will start collapsing, and that's why there is abnormal air is present in the pleural space. So air should not be present in the pleural space. And whenever the air is present in the pleural space, it is almost always equivalent to atmospheric air, which is rich in nitrogen, and the one which is present in the blood vessels or capillaries which are passing through the alveoli are not having much of nitrogen, they are having oxygen. So this creates a diffusion gradient for nitrogen. So eventually, when you see the small or asymptomatic pneumothorax, when they left on their own, they resolve. How they gradually resolve is because the nitrogen start diffusing via this gradient. In the alveolar capillary, the nitrogen content is less, whereas in the pleural space, it is more. So the pressure gradient is higher in the pleural space. So the air moves from the higher pressure to the lower pressure. So that's why there is a gradual spontaneous resolution of the small asymptomatic pneumothorax. So coming to the basic definition of the pneumothorax is the abnormal presence of air in the pleural cavity, which is separating the visceral from the parietal pleura, and there is a subsequent collapse of the adjacent lung. So what we say in a simple word is air in the pleural space causing partial or complete lung collapse. Complete lung collapse more commonly seen in tension pneumothorax. So this is a basic definition of the pneumothorax. How do we classify pneumothorax? Pneumothorax can be classified as a spontaneous or traumatic. A spontaneous, we have the primary, and we have the secondary. And in case of traumatic, where we have a trauma involved, either it can be a non-iatrogenic blunt or penetrating trauma, which is happening in the road traffic accidents or a fall. And we have iatrogenic, which is secondary or as a consequences of medical procedures. Okay, we'll see what are the procedures which leads to traumatic iatrogenic pneumothorax. So this is a basic classification which we divide into spontaneous, which happens on their own due to underlying lung disease. And when there is underlying lung disease present, it is considered as secondary. If it is secondary to some apical bleps or bullae due to some tall stature, then it is a primary, where the rest of the lung is completely disease free. So pathophysiology, I have already mentioned, the presence of air in the pleural cavity can occur through these three events if there is a communication between the pleura and the alveolus, or there is a communication between the atmosphere and the pleural space, or there is a presence of gas producing organism. So whenever you see air in the pleural space, one of these three mechanisms has to be present for the air to be present inside the pleural space. So coming to primary spontaneous pneumothorax. Spontaneous primary, where the main pathogenesis is the over distension of the alveoli, which causes the air to dissect along the bronchovascular sheath, leading to presence in the pleural space. And mainly they are because of the subpleural bleps or bullae. So bleps are small subpleural air-filled spaces. Bullae are large, that is almost around 10 millimeter in diameter, and the wall is very thin. So any of these can rupture, and there is the dissection of the air into the pleural space. So there are some genetic factors like build and stature. So the person who are having tall stature, they are subjected to be having a greater distending pressure in the apex. So when you see our lungs in a standing position, the weight is more in the base, and we see the blood flow is more at the base, and the air flow is more at the apex. And because of the distending pressure, the apex alveoli are already very much distended. Slight more distension or any exertion on coughing or a history of a trauma with the help of a hand, that can lead to rupture of these dilated or distended bleps or alveoli. So that leads to a primary spontaneous pneumothorax. And sometimes this cigarette smoking, that can lead to inflammation and thinning of these air spaces. And some genetic conditions like alpha-1 antitrypsin deficiency or Marfan syndrome, again there is a tall stature, Ehlers-Danlos syndrome. So in these conditions can also be seen as primary spontaneous pneumothorax. So what we can say in primary spontaneous pneumothorax is the characteristic of the patient is he will be tall, a thin male in between 20 to 40 years, and they definitely have some smoking history, probably a significant smoking history. You all will be wondering why I have put an image of this spring. So imagine our lungs, okay, when they are in standing position in the form of this, sorry for my drawing. So they are in the form of this spring. So when you see the base area, the lower part, you can see the coiling is very less. So you can see the distance between the two rings is very low. Similarly, when you see the apical area, this is considered as apical area, you can see the distending, the distance between the two rings is more. So when you see the spring is hanging with the weight at the bottom, the distending part is in the apical area. So this distending part, that means that the alveoli are already distended to the max. Beyond this, there will be injury to them. Whereas you see in the lower part, they are not completely distended. Okay. So that is the way of explaining the primary spontaneous pneumothorax with the help of a spring, which is suspended. So coming to secondary spontaneous pneumothorax, the term only indicates secondary to underlying lung diseases. So when we see these secondary spontaneous pneumothorax having a underlying structural lung disease, they are life-threatening. Even though the patient does not have symptoms and there is a pneumothorax, don't just wait. It is a life-threatening. He can worsen very rapidly. So the first thing we have to think is airway diseases, which are common: COPD, bronchial asthma, bronchiectasis, or cystic fibrosis. Second thing, we have cystic interstitial lung diseases, which are predominantly having cysts or honeycombing, that is idiopathic pulmonary fibrosis, Langerhans cell histiocytosis, lymphangioliomyomatosis, and sarcoidosis. In infections, the most common, which is causing pneumothorax in immunocompromised individual or HIV or AIDS individual, is PJP pneumonia, Pneumocystis jirovecii pneumonia, because they have a cystic lesion. Then we have cavitatory tuberculosis, staph pneumonia, which are leading to responsible for pneumatoceles. In malignancies, we have cavitating malignancies of cavitating primary squamous cell carcinoma of the lung or secondaries from head and neck. So they are also secondaries from metastatic squamous cell carcinoma. In connective tissue diseases, we have two important diseases like rheumatoid arthritis and scleroderma, and we have others like catamenial pneumothorax and granulomatous polyangiitis. Can anybody tell me what is catamenial pneumothorax? What do you mean by catamenial pneumothorax? I think I have discussed catamenial hemoptysis during my hemoptysis webinar. Okay, so let's see what is catamenial pneumothorax. So catamenial pneumothorax is recurrent pneumothorax occurring in a woman within 72 hours of onset of menstruation. So within 72 hours of onset of menstruation, there is a episodes of recurrent pneumothorax in a woman. So the mechanism, possibly again we have thoracic endometriosis, which is most accepted mechanism, or sometimes there will be transpleural or diaphragmatic implants, which leads to transdiaphragmatic passage of air, or air from the peritoneum via this diaphragmatic defect is entering into the pleural space. Or sometimes it can be a hormonal or endocrine in nature. So the classical clinical features include, majority of them will be on the right-sided pneumothorax, and they will be correlating the history of 72 hours of onset of menstruation, and they have recurrent episodes, and sometimes on ultrasound abdomen and pelvis, we do find pelvic endometriosis. So the treatment in recurrent cases, definitely go for surgery, because it keeps on happening unless and until you treat endometriosis, which we know it is difficult to treat. And excision of these endometrial implants can be done. If there are diaphragmatic defects, that can be repaired to prevent the passage of air from the peritoneum into the pleural space. If there are bullae, we can go for removal of the bullae. And the very important step is pleurodesis, where we cause the visceral and parietal pleura to adhere to each other so that there is no re-entry of air, no recurrence can occur. Or as an adjunct, we can also go for hormonal therapies like oral contraceptive or GnRH agonists or danazole. And the last but least, okay, in severe cases, which is not done routinely, severe or refractory cases, despite these management, if there is no improvement, then you can go for hysterectomy plus bilateral self-oophorectomy. So this is a brief about the catamenial pneumothorax. Then pneumothorax in AIDS or immunocompromised is also very, very important, because there are multiple causes in patients who are having immunocompromised state and developing pneumothorax. The most common, the very important, is Pneumocystis jirovecii pneumonia. The name only suggests pneumocysts. So they are air cysts filled with the air in the lung. Secondary to that is bacterial pneumonias, especially Staph aureus, or cyst or cavitating producing pneumonias like tuberculosis. We have certain fungal infections, and we have some viral infections like cytomegalovirus or Kaposi's sarcoma. So mainly they are seen in advanced immunosuppression, where the CD4 count is less than 200 or less than 150 or 100, and they associated with the smoking. So what happens in this is, when there is infection, there is a alveolar inflammation. So because of that, there is release of proteases, and there is a formation of subpleural cyst and pneumatoceles. So these are often bilateral because these are infectious conditions. They tend to occur in both the lungs. And since the infection and the inflammation is going on continuously, so there will be a persistent air leak. The air leak is not resolved, and the management will be ICD is must because they may worsen rapidly, and that might need a prolonged drainage because of the persistent air leak. Because of the continuous air leak from the alveoli due to infection continuously going on, the air will be continuously leaked into the pleural space. So we have to keep the ICD for a longer period of time. Despite of that also the air leak does not heal, we may have to go for surgery. So these people tend to have higher incidence and higher mortality. So a pneumothorax in an AIDS or immunocompromised patient is almost always high mortality and high incidence. So coming to traumatic pneumothorax, in traumatic pneumothorax, we have iatrogenic and non-iatrogenic. In iatrogenic, we are going to see it is transthoracic needle aspiration is the most leading cause for iatrogenic pneumothorax, followed by subclavian central vein catheter insertion, which is again leading to pneumothorax or hemothorax sometimes. And very important, which commonly we do thoracentesis, if we are going to use a three-way cannula, then yes, there is a more chance of developing thoracentesis. And transbronchial biopsy or pleural biopsies, or sometimes patient who is on positive pressure ventilation on intubation, sometimes these cavities or cyst may give up, and that leads to ventilator-induced lung injuries. Whereas non-iatrogenic includes any trauma, which can be a penetrating trauma or a blunt trauma, or sometimes due to excessive vigorous vomiting, the esophageal rupture can also give rise to hydropneumothorax. So let us see the non-iatrogenic part, which is not related to the medical procedures. There can be a penetrating trauma where direct communication from the atmosphere to the pleural space. And if the visceral pleura is also involved, then there can be air leak from the lung. So air is directly coming from the atmospheric air. And if there is injury to the visceral wall, air is also coming from the atmosphere in the pleural space. Secondly, we have blunt trauma where the rib fracture, the sharp edges of the fractured rib can lacerate the lung and rupture the visceral pleura. So because of that also there can be a pneumothorax, or there is sudden pressure rise inside the lung, then alveolar rupture can lead to again pneumothorax. So in these patients, there is a chance of pneumomediastinum also along with the pneumothorax. And sometimes we have something called open pneumothorax. Okay, so open pneumothorax is the large chest wall defect. So what happens when the patient has a large chest wall defect? Instead of the air traveling through the trachea, it starts traveling from the large defect because it is a path of least resistance. The diameter is larger than the trachea. So the air will pass through this large defect rather than passing through the trachea. So this is a worst condition where we can see open pneumothorax, where there is a sucking chest wound. Okay. So coming to esophageal rupture, what we call it as Boerhaave syndrome, where the causes can be severe vigorous vomiting, or sometimes there can be instrumentation like upper GI scopy or something will be done. So post which we are going to see there's a presence of both air and fluid that leads to hydropneumothorax, where the patient complains of chest pain and dysphagia, and sometimes due to the pneumomediastinum or the air traveling into the subcutaneous plane leading to subcutaneous emphysema and pneumomediastinum. So investigation, when you aspirate that fluid and send it for analysis, we definitely get an increased amylase level, which is of salivary origin because of the esophageal involvement. So imaging can be contrast esophagograph, that is the barium swallow, or we can go for a contrast enhanced CT chest. And because they are having high mortality, if it is missed, so they require an urgent diagnosis and a surgical management. There is no wait and watch in case of esophageal rupture. Always they require urgent diagnosis and surgical management. So coming to overall clinical features of the pneumothorax. So that was about the causes, where we covered primary, where we covered secondary spontaneous pneumothorax, iatrogenic and non-iatrogenic. In non-iatrogenic, we have penetrating blunt trauma and open chest wound. And we have a separate entity called catamenial pneumothorax and esophageal rupture. So coming to the overall general symptoms of pneumothorax, whenever there is a pneumothorax, the patients will have an acute onset dyspnea and acute onset pleuritic type of chest pain. I hope you all of you know pleuritic type of chest pain, which is lateralized in nature, increases on deep inspiration and coughing, and it is decreased when you apply the pressure over the lateral aspect. Okay, so that was about the pneumothorax. And next we have a tension pneumothorax. Tension pneumothorax, the name only suggests it is of tension to both patient as well as to the treating doctor, because the intrapleural pressure becomes greater than the atmospheric pressure. So what happens when the intrapleural pressure becomes greater? So ideally it is -5, which I have told in the beginning of the webinar in the first slide. The pleural pressure is -5 millimeter mercury when compared to the atmospheric pressure. If it becomes +5, +10, +20, +30 above the atmospheric pressure, then what happens is it will start compressing the lung. Sometimes it may compress the lung and it will push the mediastinum towards the opposite side. And at the last, it will go compress the mediastinal structures that leads to compress of the major vasculatures as well as the cardiac chambers. So what we can see here is tension pneumothorax is a medical emergency condition. So physical examination signs, what we see is if the patient has a severe large pneumothorax, then patient will have increased pulse rate and increased respiratory rate with the signs of respiratory distress, use of accessory respiratory muscles. And on physical examination, we can see the chest movements are reduced on the affected side. And on the percussion, we can see hyperresonant note and breath sounds are completely absent. Whereas in case of tension pneumothorax, we see a heart rate of more than 140. There will be cyanosis due to hypotension and hypoxia, and signs of mediastinal shift can also be present. So this hyperresonant note is very important to differentiate the massive pleural effusion and a large pneumothorax. Why we are going to tell you clinically, if you see both the large pleural effusion and a good severe or large pneumothorax, not tension pneumothorax. Tension pneumothorax we can differentiate physically, he will be in distress. Okay, whereas in case of effusion, what we can say here is there will be a stony dull note. If you take an effusion case, massive effusion, the air entry is absent, the breath sounds are completely absent, there is a mediastinal shift, there is a tracheal shift. But if you percuss, there will be stony dull note. Whereas in case of tension pneumothorax, there will be a hyperresonant percussion note. So diagnosis, the very important investigation for diagnosis of pneumothorax is, other than the clinical history and examination, we have chest X-ray. Chest X-ray diagnosis can be done by seeing the outer margin of the lung. That is, we are going to call it as a visceral pleural line. And it is separated from the chest wall and making a lucent shape space. So this is a chest wall. And you can see this is a lung. Okay, so this is a visceral pleural line. This is our visceral pleural line. And this is the lucent space, what we see. And this is the chest wall. Okay, this is a chest wall. So what we see here is the lucent space that is the present there. That is a confirmatory for pneumothorax. And what we see in tension pneumothorax is the mediastinal shift, diaphragmatic depression, and rib cage expansion. So don't worry, I'll show you a lot of images and chest CTs. So you'll get an idea of it. So coming to the pleural line is very, very important to diagnose a pneumothorax on a chest X-ray, and it should be differentiated from a skin fold, should be differentiated from the clothing, should be differentiated from the tubing or any chest wall artifact. Okay, so don't confuse this pleural line. I'll tell you, theoretically, it is easy to tell how to differentiate, but when you see the X-rays, I'll show you a few X-rays where you will get literally confused with the mimics of this pleural line. So coming to the first important is artifacts or skin fold. Always remember, they do extend beyond the thorax. Artifacts and skin fold, they do extend beyond the thorax, but the pleural line does not extend beyond the thorax. And the pleural line is almost always parallel to the chest wall shape, okay, entire the length, whereas the artifact is not parallel to the chest wall shape. And the pleural line is almost always the convex towards the chest wall, whereas the inner margin of the bullae or cyst is concave towards the chest wall. So how to differentiate? Imagine this is a chest wall. Okay, so it is a convex in pneumothorax. If this is a chest wall, okay, this is concave. So the bullae and the cyst will be like this, pneumothorax will be like this. So convex and concave towards the chest wall help you differentiate the pneumothorax and the bullae or a cyst. So let us see a few images. Okay, so this is an X-ray showing hypertranslucent lung field here. Okay, you can see the markings, can see the white markings here, but here there is complete absence of marking. Okay, and if you want, I'll change the color. Yes, This yellow line is the visceral pleural line. Can you make out this visceral pleural line? Okay, and you can see the rib spaces here. Okay, the rib spaces are increased. And you see the diaphragm on the left side and right side and left side. And there is a minimal blunting of left costophrenic angle. So there is a minimal fluid, what we tell it as minimal fluid. So you can see this area is considered as pneumothorax, and you see this is convex. Okay, and it is almost running parallel to the chest wall. It's almost running parallel to the chest wall. So you understood this is a clear-cut case of pneumothorax, but there is no gross mediastinal or a tracheal shift. Okay, there is no gross mediastinal or tracheal shift. So what are the signs? Peripheral hypertranslucent area, I already mentioned. Devoid of bronchovascular markings are not there. Collapsed visceral pleural line medially and collapsed lung. This is a collapsed lung. Okay, what we see here, I'll mark with a green color. So this is a collapsed lung. So the green color is a collapsed lung. Okay. So again, can you see this, the second X-ray? Can anybody see the pneumothorax? Which side of the pneumothorax is there? Can anybody make out which side pneumothorax? Is there any mediastinal shift? Can you see the visceral pleural line? Can you see the visceral pleural line? Can you make out it is parallel to the chest wall? Okay, so let us start marking. Okay, so this is a visceral pleural line. Okay, and you see it is almost parallel to the chest wall. Okay, and you see this underlying lung has some infiltrates. Okay, that means it is a secondary spontaneous pneumothorax, and you see this area. Okay, this area is devoid of any marking. Okay, this is almost like a lucent area, right? Can you make out this? So this is also a case of left-sided secondary spontaneous pneumothorax. Can anybody tell me where is pneumothorax? Yes, everybody is telling right. Yes, you guys are right. Okay. So this is not. You can see the black arrow, which is representing a homogeneous opacity right lower zone. Okay, and you can see the red marking. So see this red marking which comes here is a visceral pleural line, and this is the area which is devoid of any marking. Okay, and you can see there is small bandage here. It is not a easy case. So it is a case of iatrogenic. Okay, post biopsy, there is a iatrogenic. Yes, it is an iatrogenic pneumothorax. Iatrogenic pneumothorax. Okay, can anybody tell me where is pneumothorax? In this case. Right upper. No pneumothorax. Yes, Dr. Vinay Gandhi has told no pneumothorax. How many of you agree there is no pneumothorax? Right mild pneumonia. No, my question is whether pneumothorax is there or not there. I don't want other findings. Other findings are there. Yes, definitely. I don't want to go in detail about those. Whether pneumothorax is there or not there. Not there. Can anybody substantiate why it is not there? Okay, so what I have told you is the visceral pleural line is convex. Okay, so you can see this area is only hypertranslucent. Okay, and these are some spotty parenchymal calcification. Okay, these are some spotty parenchymal, and you can see the hilum. Okay, hilum is almost pulled up. Okay, so these are some fibrotic changes, and this represents there is a bulle. It is not convex, or you cannot see a clear-cut visual pleural line. Yes, it can be confused. It can be confused with the pneumothorax. So it's a upper zone bulle with bilateral parenchymal calcification. Now this patient, can anybody tell? Pneumothorax is there or not there? Not there. Dr. Hima is telling not there. Yes, it's there. It's there. Okay. Not. No. S. No. S. So still confused. Okay. I'll clear your confusion. You can see right side, it is just because of the exposure, it is appearing black. That it is not pneumothorax because you cannot see a visceral pleural line. And you can still see the markings. Okay. And on clinical examination, there is presence of air. Okay. But what we can see here is one line. Do you think it is convex towards the chest wall or concave towards the chest wall? Definitely, I'll agree there is a absent bronchovascular marking. But do you see this line to tell it as a visceral pleural line, whether it is concave or convex towards the chest wall? Yes. So if it is concave, then what it can be? Is it a pneumothorax if it is concave? No. So again, it's a case of left upper zone bulle. Patient was a chronic smoker and patient came with this incidental finding on the X-ray. Okay. There is a pneumothorax. This is an elderly patient. Cough with expectoration, breathlessness. If everybody is telling yes, then you guys are wrong. Intentionally, I have kept this X-ray after the bulle because to confuse you. First of all, I told you, yes, Vinay Gandhi has told it is skinfold. See, if I'm tracking it, tracking it, tracking it, tracking it, tracking it. Okay. So what was the point for skinfold, which I have told in the finding? It extends beyond the thorax. Correct? And elderly patients, they have a loose skin fold. So when you take a bedside X-ray, it is mentioned here, bedside. Okay, patient will not be having a proper positioning for the chest X-ray. So, and also it is not convex. You guys forgot it is not convex. You can see the scapula is also coming in the lung field. Okay, ideally the scapula will be away from the lungs for better visualization of the lungs. So this is not properly positioned X-ray, and you see the skin fold is going beyond the chest wall. So this is a thoracic cavity and it is going beyond. So this part you can see. So this is a artifact which is due to skin fold, which is a mimicker of pneumothorax. So don't just rely on chest X-ray, hypertranslucent lung field. No, you have to be very, you have to be sharp. Okay, you have to have very sharp eyes and a sharp ear. So auscultate this patient. Okay, if you have a confusion with your eyes, auscultate. If you find air entry is there, less likely it is pneumothorax. Less likely it is pneumothorax. Okay. So have you heard of grading of pneumothorax? Have you heard anytime how do you grade pneumothorax? Anybody of you heard how to grade pneumothorax? So according to the guidelines of the BTS, British Thoracic Society, and ACCP guidelines, what we tell here is the apicocupular distance. Okay, so this is a visceral pleural line, okay, collapsed lung, and this is a chest wall. So entire length we don't have to take, only till here. Okay, so this length is enough. So this length, if it is more than 3, it is considered to be as a large pneumothorax. And at the level of hilum, if you see only till here, okay, visceral pleural line, only till here, if you take this much length, if it is more than 2, then it is a large pneumothorax. So British Thoracic Society, their hilum level 2 centimeters. So how to remember? B is a second word, second letter. So 2 number. Okay, apicocupular is 3. Okay, apicocupular is 3. Okay, so you remember it like that. And there are other methods are also light index Collins RIA, which is not routinely used. This is also not routinely used, but just for your knowledge, if you have to grade pneumothorax, this is how we have to do it. So coming to ultrasound thorax is more sensitive than chest X-ray for detection of pneumothorax. Of course, when I have told about the pleural effusion, ultrasound is considered to be as more sensitive when you diagnose a small minimal pleural effusion, because it needs up to 5 to 10 ml of fluid for diagnosis. Whereas chest X-ray needs around 50 to 150 ml for just blunting of costophrenic angle. So ultrasound is considered to be more sensitive, and it can be done at bedside, and it is not having any radiation exposure. So these are the advantages of ultrasound compared to the chest X-ray. So what are the points which we see here is absence of normal lung sliding. So normally when you see a real-time ultrasound, the lungs are sliding over the chest wall. So you can see the normal lung sliding is there. Okay, obviously when there is air between the visceral and parietal pleura, the lung sliding is not seen on the ultrasound. And there is something called lung point. I will explain these things, and stratosphere or a barcode sign, which is seen in the normal lung, in the pneumothorax, and normal lung shows a seashore appearance. I'll tell you about this. So absence of normal lung sliding means the lung sliding is absent. So it is not very specific, because if the patient had a previous history of pneumothorax and underwent chemical pleurodesis where both the pleura are adhere, then again the lung sliding is absent. Okay, or maybe due to recurrent pleural infections or pleural effusions, there will be pleural adhesions or fibrosis. Or sometimes the lung is collapsed due to endobronchial tumor or mucus plug. Again, there will be no lung sliding. So absence of normal lung sliding is not very specific. Whereas presence of normal lung sliding will rule out pneumothorax. Okay, you can easily rule out pneumothorax. Whereas something called lung point. Okay, so lung point is something like this. This is a chest wall. So it represents the boundary between the collapsed and the aerated lung. For example, if there is a pneumothorax like this, so this is a pneumothorax area, and this is a normal aerated lung. So this point, okay, if you keep an ultrasound probe, we are going to call it as lung point. Okay, so aerated lung is seen sliding into this field, and whereas here there is absence of lung sliding, and it is very, very specific for pneumothorax. Okay, so to differentiate absence of lung sliding, other differential diagnosis, you have to do a lung point, and lung point, if you see, that is very much specific for pneumothorax. So you can see the normal lung here in the M mode, okay, ultrasound. So as I already mentioned, seashore is a normal where there is no motion chest wall. This is chest wall, and this is a moving lung. So you can see the moving lung will have a positive motion lung beach. So this looks like a beach. This is a sand, and these are the water waves. So it is a seashore sign. When you see there is no motion, and here also there is no motion, so it will become almost same. So you have seen in the supermarket, there is a barcode for all the products. They scan the barcode and they get all the details. So this looks like a barcode or a stratosphere sign. So this is a barcode or stratosphere sign on M mode, which is representative of pneumothorax. So ultrasound is always and always better than chest X-ray for bedside diagnosis, especially in case of ICUs and emergency where the patient will not be able to shift and there will be no much time to diagnose pneumothorax. And sometimes supine chest X-rays may miss pneumothorax, maybe due to artifact or not due to a proper positioning or the exposure. So these are some drawbacks of these investigations. Coming to the CT thorax is more and more sensitive and accurate compared to chest X-ray. Okay, but it needs transportation of the patient, shifting of the patient, where it is difficult in ICUs and emergencies, and there is a radiation exposure. But it helps in differentiating between large bullae and pneumothorax. I'll show you the images. And sometimes these small pneumothorax, which are present in the apex, which are hidden behind the rib shadow in the chest X-rays, can be picked up by the CT thorax. So this is a case of CT where you can see collapsed visceral pleura. Okay, this is a lung, collapsed lung. and you can see some amount of fluid, and this black is air. Okay, so this is a right-sided pneumothorax, and this is the differentiating point of bulle. So you can see this thin-walled, okay, thin-walled bulles. So don't get confused with these and directly go for ICD insertion. So confirm, okay, these are thin-walled, more than 10 mm diameter bulle. Okay, so this is how the chest X-ray looks: a well-defined, collapsed lung, and clear cut without any septations. And here you can see it is different. So coming to the management aspect, that was about the diagnosis. So diagnosis, we have clinical finding, we have seen the chest X-rays, we have seen how to differentiate the skin fold, how to differentiate the bulle on the chest X-ray, and then we have graded these pneumothorax according to the guidelines. Then we saw what are the advantages of ultrasound, what is the normal appearance of the ultrasound, seashore sign and a barcode sign, and what are the indications and advantages of CT thorax. So coming to the management aspect, the old management was observation for any patient who is asymptomatic or mild symptoms, and there was a quantification less than 20% of the unilateral pneumothorax, sorry. But now recent guidelines of British Thoracic Society 2023 onwards, they have shifted from size-based to symptom-based approach. Even though the pneumothorax is more than 20%, if the patient does not have symptom or patient is hemodynamically stable, still you can go for observation, especially for primary spontaneous pneumothorax. If it is secondary spontaneous pneumothorax, you know the underlying lung is not having a proper cardiopulmonary reserve, then there is no point of observation. Directly you have to go for intervention. The one more myth we are going to burst here is supplemental oxygen increases the rate of absorption of the pleural gas. So I have asked you in the beginning, many of you have answered no. Supplemental oxygen definitely have a role in increasing the rate of absorption for pleural gas. I'll explain you why. So why this oxygen speed up resolution? So in a simple way, I will tell you what I have mentioned in the first slide is pleural space is having atmospheric air. Atmospheric air is rich in nitrogen. So pleural space is rich in nitrogen. And this air has to be diffused into the alveolar cavity for the resolution of the pneumothorax if you are going with the ICD insertion. So for small pneumothorax, will take place via the pleural space into the alveolar capillary, because alveolar capillary are having less nitrogen when compared to that of the pleural space. Correct. So what happens is when you give a very high flow oxygen, whatever the remaining nitrogen is also there, it is getting washed out in the alveolar capillary. So you are increasing the pressure gradient. So this is alveolar capillary nitrogen going down, and this remains same. So what happens? Initially the pressure difference was this without oxygen. When you give oxygen, there is further decrease in nitrogen level in the alveolar capillary, so that the resolution or the diffusion of this air will take place faster. So this is a simple definition why oxygen is given in patients of pneumothorax. But be careful, if patient is having secondary COPD, you should not give high flow oxygen and cause CO2 narcosis. So just to rule out all the structural lung disease and the diagnosis, and then you can go ahead with the high flow oxygen. So same thing is there. Washout will be there of the nitrogen by increasing the gradient, and more nitrogen moves from the pleural space to blood. Along with this, the additional effect can be if the patient has hypoxia, it will improve the oxygenation and reduce the hypoxia. So you can see the air in the pleural space, there will be nitrogen. Okay, when you increase the oxygen content, you can see the nitrogen is again reducing. So because of that, there will be easy and faster diffusion of the nitrogen from the pleural space into the alveolar capillary. So coming to next management, where we see the first is observation. Now we go for aspiration or decompression. So as we do for pleural fluid, we also have pneumothorax. A 16 or 18 gauge catheter can be used. Initially, what they tell is second anterior intercostal space, but because of the obesity or some patients who are having trauma, the anterior aspect will be not accessible. So now they have told anterior axillary line in the fourth or fifth intercostal space can also be used as an aspiration. So when you use it, same needle with a small bore, then we can call it as aspiration. In case of tension pneumothorax, you are going to use a large bore, and that is called decompression. Decompression means suddenly you have to remove a large amount of or large volume of air. So that is called decompression. The instruments remains the same, but the procedure is different. Decompression is sudden removal of the air because there is a pressure is higher than the atmospheric pressure, causing the cardiopulmonary compromise. But in case of second pneumothorax, which are primary spontaneous, we can go for aspiration, slow removal of the air. Coming to the ICD insertion, already mentioned about this in pleural effusion. I'll again brush up few points. It's a standard method for removal of intrapleural air, where we use a 20 to 24 French size in uncomplicated cases, and in slight complicated case, we use a large bore. And definitely it is placed in the safe triangle. And these are few theoretical indications like tension pneumothorax, or patient is on ventilator, or patient has bilateral pneumothorax, or patient has previous recurrent pneumothorax, or patient had a large or complete pneumothorax, or presence of pleural fluid, that is hydropneumothorax. So these are few theoretical indications for intercostal drain insertion. So you can see, again, I have already mentioned in triangle of safety, it is one of the important triangle where we can anteriorly bonded by pectoralis major muscle, posteriorly bonded by latissimus dorsi, and above by base of the axilla, and below by fifth intercostal space. So it's a triangle of safety, better for insertion of intercostal drain. So when to remove ICD in a patient of pneumothorax? There is no air leak. Air leak means when you have inserted the ICD, you have to keep checking the bag, the collection bag. Okay, when the patient is inhaling or exhaling. When the patient inhales, the air enters into the alveoli. If there is a leak in the alveoli, that air will directly pass into the pleural space, and from the pleural space, it will go into the tube, and then there will be bubbling in the collecting bag. That is a air leak during inspiration. If the patient exhales and you see there is air leak, it is air leak during expiration. If the patient is not having air leak during inspiration and in expiration, then you have to ask the patient to cough. When the patient coughs, there is a forced expiration. Again, when you see the bag, if there is a bubbling, it is air leak against forced expiration. If the patient is having both inhalation, inspiration and expiration air leak, then it is called continuous. So these are the four grading: continuous in both inspiration, expiration, only in inspiration, only in expiration, forced expiration, where you ask the patient to cough. So this is how it goes in severity. Continuous is more severe, inspiration is less, expiration is lesser, and continuous expiration is in the healing phase. So the patient should not have any air leak or bubbling in the collecting bag. Then only you have to plan to remove ICD. And the lung has expanded both clinically as well as radiologically, and patient's clinical condition has improved. So these are the three important criteria for removal of intercostal drain. So this is a trocar with ICD, and this is a collecting bag. You can see till here we are going to fill the normal saline or distilled water, and then we can see here bubbling in this bag. So this is a case. You can see this patient. I'll show you the visceral pleural line. Again, you can see it is parallel, but here again it is not extending till up. It is coming like this. So this is a collapsed lung. Again, still you can see it is convex. It's parallel to the chest wall. It is not extending beyond the thorax, and there is no mediastinal shift. So you can see the ICD is inserted here. ICD is inserted here, and you can see the bandage outside, and you can see clearly the lung has expanded. Clearly the lung has expanded. So this is not normal. You can see there's a pneumothorax, and ICD is inserted, and the lung has expanded. Okay. So coming to the pleurodesis, the first part was observation, then there was aspiration or decompression. The third was intercostal drain, which is a standard method. And now we have for recurrent, if there is a recurrence of pneumothorax, how to deal with it. So we have pleurodesis. We have already mentioned in the pleural effusion, if there is recurrent pleural effusion, recurrent pneumothorax, then we are going to adhere both the visceral and parietal pleura. So this is obliteration of the pleural space by instilling, either it is chemical or mechanical. We are going to instill chemical agents, that is called chemical pleurodesis, or sometimes we can go for mechanical, where we are going to abrade and cause the inflammation and fibrosis. So indication is recurrent effusion, recurrent pneumothorax. We can go for adherence of these visceral and parietal pleura. So you can see the parietal pleural space, visceral and parietal pleura will be adhered because of the fibrosis. So coming to the last entity of the treatment, where what are the indications to perform surgery in a patient of pneumothorax? So already I have told you, if patient has a persistent air leak or failed initial treatment, then it is indicated for surgery. Or patient has recurrent pneumothorax due to any other etiology, then we can think of the surgery. Underlying lung diseases like bullous lung disease, we can go for bullectomy. Especially patients who are having high risk occupations, especially those who are having pilot and scuba diver, because they are exposed to extreme atmospheric change. So there is a change in pressure, so they have increased incidence of developing recurrent pneumothorax. So in those cases, as a prophylactic, they can go for surgery. or bilateral pneumothorax, or sometimes in selected cases of tension pneumothorax, where despite of optimum management, there is no improvement in the patient's clinical condition. So these are the two important surgeries what we use, that is VATS, that is video assisted thoracoscopic surgery, which is preferred, and we have open thoracotomy. This is minimal invasive. We can identify the air leak and close with the help of stapling, and we can also remove the bullae or blebs. Simultaneously, we can perform pleurodesis to prevent recurrence. Whereas in open thoracotomy, it is used in complicated cases or recurrent case where the recurrence is lower, but it is more invasive, and more post-operative care is required. So these are the two comparisons what we have seen. Okay, so the diagnostic yield or the recurrence is less when compared to that of the open thoracotomy is having more chances of cure, and the recurrence rate is less, but the recovery time is more in case of open thoracotomy. So you can see this is how, with the help of a camera, we are going to do VATS pleural procedure, and this is how we do open pleural procedure. So coming to the management tailored to the individual type of pneumothorax. So primary spontaneous, since I already mentioned, tall, thin individual with because of the subpleural bleb or bullae. If it is small and asymptomatic. Okay, so here you can see both size and symptoms are mentioned. So what is the latest guidelines telling? Yes, the symptoms will decide the treatment, but the size will support it. So if it is a small size asymptomatic, obviously you go for observation and oxygen, because oxygen helps you to resolve the pneumothorax in a faster time. If it is large and symptomatic, first you have to go for needle aspiration, and if it is failed, go for intercostal drain. Persistent air leak, always go for surgical referral. And when do you call it as persistent air leak? Different guidelines shows different, but average is 3 to 5 days. Sometimes they tell more than 7 days. Okay. So coming to secondary spontaneous pneumothorax, which I already told you, you don't have to go for observation in these cases because they have underlying reduced pulmonary reserve. So most of the cases we have to go for intercostal drain. Even small pneumothorax can cause hypoxia in such patient. After expansion, we have to plan for pleurodesis if there is a chance of recurrence or a high risk occupation. Again, if there is a persistent air leak, if he is fit for the surgery, then you can go for video assisted thoracoscopic surgery. Whereas in case of immunocompromised AIDS or pneumocystis jirovecii related pneumonia, again, we are going to go for intercostal drain because they have high recurrence. So after expansion, if they're fit for pleurodesis, definitely go for pleurodesis. If there is persistent air leak, we can go for VATS. If it is unfit, we have to go for Heimlich valve, which is a one-way valve where the air will enter and it will not come out. So that is what we are going to use. Whereas in case of traumatic pneumothorax, almost and always you go for large bore ICT because there is associated hemothorax. There will be presence of blood. So for drainage of that blood, we have to go for large bore intercostal, and patients who are on positive pressure ventilation don't delay because they are having high risk of developing tension pneumothorax. So always go for intercostal drain insertion. So complications of these pneumothorax can be tension pneumothorax. Yes, any pneumothorax can be developed into tension pneumothorax. Patient may have bronchopleural fistula, and if the patient's lung is collapsed for more than 3 days and suddenly it is re-expanded, that leads to re-expansion pulmonary edema. Recurrence, infection, and hemothorax can be associated or post episode complications of the pneumothorax. So this is an overview of tension pneumothorax. What we see is a one-way wall effect. What I have already told you, the pressures are beyond the atmospheric pressure. So in inspiration, the air enters. In expiration, the air will not go out. So it's like a one-way wall effect. Okay, so we can see there is a collapse of lung, mid-diastole shift, venous return will decrease, and cardiac output will reduce. So patient will have severe dyspnea, tachycardia, hypotension, neck veins are distended. Okay, and you have to suspect when the pneumothorax patient has a sudden deterioration, or patient is on mechanical ventilation, is getting collapse, or following any procedures like central line or transthoracic needle aspiration. So supportive management can be high flow oxygen. Okay, and don't wait, directly go for needle decompression either in the second intercostal space, mid clavicular line, or fourth to fifth intercostal space, anterior axillary line, and immediately go for intercostal drain insertion. So you can see the X-ray, the difference, the tension pneumo and the simple pneumo. So you see the X-ray, okay, almost the right lung is gone and it is pushing the cardia. You can see the cardia is almost on the left side. Okay, so this complete area is a hypertranslucent lung field without any marking. and you see the diaphragm is having very deep, okay, angle. And you see almost the ribs are horizontal. Ribs are almost horizontal. So this is a case of tension pneumothorax. So either immediate needle decompression or intercostal drain, if it is available directly, we can go for ICD. So coming to bronchopleural fistula, as the name suggests, there's a fistula between bronchus and pleura, and that leads to air leak. So there's a communication, and this air leak can persist even after chest tube. So usually it seals in 24 to 48 hours. If it persists beyond that, it is called persistent air leak, which occurs in 3 to 5%. Still, we can wait up to 7 to 10 days. And if the lung is not expanding and the air leak is persisting, you can go for these three options, either surgical option, bronchoscopic option. We can instill some sealants which can go and block those air leak, or there is something called autologous blood patch, where we draw the patient's blood and instill into the ICD so that this blood will get clotted into the air leak. Okay. So coming to re-expansion pulmonary edema, what did re-expansion pulmonary edema tells is it is a rapid re-expansion of a collapsed lung. Okay, and it is a serious complication. And the risk factor is the lung should be collapsed for more than 3 days, that is 72 hours. If it is 1 day lung collapse, it won't happen. Less likely it will happen. If it is collapse for a longer time, definitely it will happen. And there is a rapid drainage, which is very difficult to control in case of ICD, in case of pneumothorax. Or sometimes we apply higher suction. Okay, if it's non-expanding lung, sometimes we apply higher suction, suddenly it will expand. So that can also lead to re-expansion pulmonary edema. It is mainly because of the capillary injury and leakage of fluid into the alveoli. So it's like a unilateral pulmonary edema. Patient will start having persistent cough, chest pain, and dyspnea, and that patient may go into hypoxia. So we have to go for a conservative management with supportive care, or non-invasive or mechanical ventilation can also be given. And it is a self-limiting. Most of the patients will recover fully in 24 to 48 hours if we give a symptomatic management. So coming to few MCQs. So are you guys ready for MCQs? Okay. So here is a 22-year-old tall male develops spontaneous pneumothorax. Which of the following best explains the predisposition of apical alveoli to rupture? A, B, C, D. Is it because of increased perfusion at the apex, higher compliance at the apex, or greater negative pleural pressure at the apex, or reduced ventilation at the apex? So it's a primary spontaneous pneumothorax, right? Yes, because of the distending pressure of the alveoli is more at the apex. I have explained in the spring theory, the negative pleural pressure is more. So because of that, the alveolar distension is more. So because of that, they may give away, and that leads to a primary spontaneous pneumothorax. Okay, very good. A 58-year-old smoker with COPD presents with, yes, we have measured 1.5 centimeter pneumothorax. It is according to BTS. Again, we have to specify, okay, and mild dyspnea. What is the appropriate initial management? Observation with oxygen, observation, needle aspiration. I think you guys are not noticing it is a secondary spontaneous pneumothorax. The patient who is a smoker and COPD, I'm telling. So there is an underlying pulmonary compromise. So you don't have to see the size, you don't have to see the symptom. You directly have to go for ICD, because these patients, even with a small pneumothorax, they may end up into developing hypoxia. Okay. So patient with pneumothorax is given high flow oxygen. What is the mechanism that explains you, which accelerates the resolution of the pneumothorax? Yes, we are reducing the nitrogen in the blood so that there will be an increase in gradient or difference. So that the nitrogen will pass from the pleural space into the blood. So this is how the oxygen helps in resolving the pneumothorax. So from now onwards, you should know why oxygen is given and for what purpose the oxygen is given in pneumothorax. The patient suspected of pneumothorax undergoes bedside ultrasound. Which finding is most specific for pneumothorax? We all know absence of lung sliding is also seen in other conditions. Okay, we have only lung point, which is the point or junction where there is normal lung and the pneumothorax. So that helps you to clearly diagnose the pneumothorax. Yes, we have barcode sign. Definitely we have barcode, but it is not most specific. Okay, most specific is lung point. So coming to 32-year-old man presents with right-sided pneumothorax of 4 days duration. ICD was inserted, rapid evacuation of air, and also the suction is applied. Within 1 hour, he developed cough, dyspnea, hypoxia. Chest X-ray revealed crackles. What is the mechanism? So it's a clear-cut case of re-expansion pulmonary edema, and the mechanism is, yes, the collapsed lung. You can see the duration is 4 days. Duration is 4 days. Okay, and within 1 hour he has developed this, and there are crackles over the affected site. So more likely it is perfusion injury. Okay. So coming to a case, we have 2 cases. We'll solve these 2 cases and then we are going to end this webinar. So 48-year-old male, chronic smoker, progressive breathlessness since 2 years, worsened since last 4 days, left-sided pleuritic type of chest pain, does not have any fever or hemoptysis or recent trauma. There is a history suggestive of underlying chronic lung disease. On examination, he was in distress with tachycardia, tachypnea. BP is okay. So saturation is also 90 on room air. Local examination, trachea is central, expansion is reduced on the left side, hypersonant note is percussed, and absent breath sound. Investigations also did not reveal any significant abnormality. Chest X-ray showed hypertranslucent left hemithorax, visible visual pleural line, absence of peripheral lung, collapsed left lung seen medially, no mediastinal shift. Intervention was done. Left ICD was inserted because it is a secondary spontaneous pneumothorax. So you can see this is a visceral pleural line, right? The initial X-ray, and you can see the X-ray. You can see the ICD is inserted till here, and this is how the post ICD X-ray. So let's continue the case. In 6 to 8 hours, patient developed sudden worsening of breathlessness. Patient's requirement of oxygen has increased. Chest X-ray was repeated, which showed ill-defined homogeneous alveolar opacities involving the re-expanded left lung. So this is a repeated chest X-ray. You can see lung has expanded, but it has a ill-defined alveolar opacities. And patient's clinical condition, again, it is worsened. Okay, and patient's oxygen requirement is increased. So you can see, yes, okay. So what is the most likely cause for post-procedure deterioration? Why he has deteriorated? Did the tube get blocked or tube is malpositioned? Yes, is again a case of re-expansion pulmonary edema. So when you see here, yes, tube is intact, tube is not having malposition, tube is also not blocked. Okay, we can see there is no residual pneumothorax. Okay, lung has completely expanded, but it is filled with non-homogeneous densities. That means you can see the history here carefully. Again, the patient had worsened over last 4 days. Okay, there is sudden re-expansion. So that's why it looks like an unilateral pulmonary edema. And patient was managed conservatively without any other intervention. And this is just a 1-day X-ray. You can see repeat X-ray. You can again track the tube till here, and you see the opacities have cleared. Okay. So this is a real example of re-expansion pulmonary edema. Okay. So again, the same thing, re-expansion pulmonary edema, you have to manage conservatively, and you don't have to panic, or you don't have to think and go for reinsertion or removal of ICD and again go for reinsertion. No need to do that. Okay. Calm down and just rule out other causes of cardiac failure or like pulmonary embolism, tachycardia and all. Then you can go for expansion, pulmonary edema. Coming to second case, 65-year-old man with COPD presents with mild breathlessness. Okay, and he's stable but hypoxic. His saturation is on the lower side. Chest X-ray shows a pneumothorax. We have not quantified, we have not told how much percentage or how much centimeter, just a pneumothorax. What is the most appropriate management? I'm asking repeatedly because you should know. Because when you're practicing, you should know whom to go for intervention, whom not to go for intervention. Yes, again, this time you got right. Patient who are having COPD, secondary spontaneous pneumothorax, patient though he is stable, okay, these pneumothorax can worsen very fast and they may develop hypoxia soon. So it's a life-threatening condition, go for ICD. So treat aggressively, even small pneumothorax, we have to give ICD. So coming to your myths, we are going to burst. So this was the first myth, small pneumothorax can be safely observed. Yes, if it is stable and symptoms are minimal, guidelines says that if the symptom-based approach rather than a size-based approach, yes, they can be safely observed and given oxygen for faster resolution. Tension pneumothorax always presents with hypotension. No, it is a last sign. It is not necessary that it has to be always present with the hypotension. The word always is very important. Yes, may or may not be. They may have tachycardia, they may have tachypnea, they may have respiratory distress with mid-diastolic shift. Not necessary they should have hypotension. It may develop in the later stage because of the decreased venous return and decreased cardiac output. So it is not almost always present with hypotension. Chest X-ray is sufficient to rule out pneumothorax. No, we have seen ultrasound is more sensitive, CT thorax is more sensitive for diagnosis of pneumothorax. Even in small pneumothorax, bullae or blebs, they are more better seen on CT when compared to that of the chest X-ray. All pneumothorax patient needs chest tube. You already have answered no. Yes, stable patients, they need observation. Sometimes they can go for aspiration. Not necessary always we have to go for an intercostal chest tube insertion. Giving oxygen helps pneumothorax resolve faster. Most of you have answered no in the beginning, but I think after this webinar, you came to know how oxygen will help in patients of stable pneumothorax. Yes, it definitely helps reducing the nitrogen and faster air absorption. Absent breath sounds almost always equal to pneumothorax. No, it was a mixed response. It is also seen in effusion, collapse, or sometimes in severe COPD, where there is decreased air entry, can also be appreciated in COPD. So absent breath sounds is not almost always equal to pneumothorax. So this is a disclaimer and this is a feedback. And I always tell ear is more faithful instrument than the eye in chest disease. Okay. Thank you very much.
Thank you, doctor. Thank you so much. Uh, Doctors, we have feedback form and certificate form listed, displayed in the front in the screen. You can scan the QR code and submit your uh, registration to get your certificate. I will also drop the certification link in the chat box. Meanwhile, Doctor, can we open the Q&A session? So I think we already have a few questions on the chat box. Let me scroll back and read it out to you. Uh, The Twinkle is asking I think, I don't know whether you answered it or not. Is any neurothorax it worsen when PT on knee support initially? Doctor, sorry, yeah, you can unmute now.
Yeah, I was unable to unmute. I
Sorry,
think
sorry.
there was a question. Actually, I'll just scroll up and see.
Yeah.
It was there. I just wanted to answer at the end.
I think is any neurothorax it worsen when
Yeah,
RT?
is any pneumothorax it worsen when patient on NIV support initially? Yeah, definitely, because we are giving high pressure NIV or mechanical ventilation. Definitely, they have a high risk of tension pneumothorax, which I already explained in my last few slides. So always a patient who is on NIV or a mechanical ventilation, if patient develops pneumothorax, you have to go for ICD insertion because they have increased risk of developing pneumothorax. That's true.
Uh, Dr. Bola is asking, it occurs when a collapsed lung is reinflated. I think that it was a comment to one of your explanation. I think it is not a
Yeah, it
question.
was a comment for
Yeah, yeah, yeah.
pulmonary edema, and it is very well written. Yes,
No.
definitely it happens due to rapidly expanding of the lung, and because of that, there is a capillary perfusion injury. Yes. There are any questions? I hope I'm clear with the pneumothorax to some extent. And I just wanted to burst those myths or fact, okay, so which we have faced in our day-to-day practice, and I think most of you have faced, and I think you guys have learned something new today, which you felt it was not there in pneumothorax.
Chat Q&A session is open. You can drop in your questions. Dr. Sohail will be able to answer your questions. I have, Dr. Dinesh, I have pasted the form in the chat box. Doctors, one kind request from our end. Please submit your form properly so that the certificates will be sent to your inbox at the very moment you click on submit button. If in case you might not, if you don't found your certificates in inbox, sometimes due to unavoidable circumstances, I don't know why it is happening. We are trying to fix it. It will land in spam folder. Uh, Please go and check in spam folder. You'll find your certificates there.
And definitely do you give your feedback, because your feedback help us grow, and we as a Mediversal team, we do see your feedbacks and take input from students. What are the USG findings in hydropneumothorax? This is a combination of both pleural effusion and a pneumothorax finding, and you can see the lung point, you can see the seashore sign, barcode sign, and you can also see there is absence of lung sliding, and in lower part you can see the findings of pleural effusion, which I have already mentioned in my previous webinars, where you can see sometimes collapsed lung. So yes, there are combination of both findings of ultrasound in hydropneumothorax. There is nothing specific to diagnose as hydropneumothorax.
Uh, Thank you, doctor. Thank you so much for joining us this evening and shedding this uh, light on this very particular topic. I would extend my sincere regards to you, doctor. And I thank for all the doctors to joining us today. We have more webinars planned for the month. Please find yourself available to our sessions. Let me also drop in our social media channels wherein you can find information about our upcoming webinars. Thank you so much. Thank you, doctor. Thank you all.
Thank you, Vijay. Thank you, everybody. Thank you for your patient listening. Good night.
Good night.